All right. Our second speaker is Dr. Ezra Gayawan from Federal University of Technology, Akure, Nigeria. And Dr. Ezra going to talk about an assessment of the impact of women's empowerment on childhood vaccination coverage in Nigeria. It's a spatial temporal analysis.
Thank you so much. Thank you so much for the opportunity to present what we are doing at the Federal University of Technology, Akure, and which is also a part of the Vaccine Impact Modeling Consortium work. So we are looking at the impact of women empowerment on childhood vaccination coverage in Nigeria, a spatiotemporal analysis. Sorry. So vaccination has contributed a great deal in reducing morbidity, illnesses, and even disability among children in particular. However, vaccine-preventable diseases are still wreaking a lot of havoc among children in low and middle-income countries because many of them still suffer from morbidity and mortality as a result of these preventable diseases. And it is getting more challenging to reach the 20% of children, the last 20% in these settings, that's in the low and middle income countries, to receive basic vaccination. SDG3 underscores the importance of achieving universal health coverage, including access to affordable vaccines and medicine for everyone, regardless of the location where you find yourself. In many low and middle income countries, gender disparity and women disempowerment are major barriers to healthcare utilization, including the uptake of immunization services. Women play some critical roles. They are often the ones in charge of the children, the caregivers, and all that. Yet they face some structural barriers that prevent them from accessing vaccination services as a result of the many challenges and constraints they face. So their level of literacy, their decision-making prowess, and access to resources can influence their ability to ensure that they get vaccination for their children and, in fact, for the entire household. Now, in Nigeria, in particular, which we are focusing on, it is predominantly a patriarchal society where gender segregation and stratification that limits the role of women are particularly common. Like we heard it in the morning during the plenary sections, and we discovered that there are a lot of constraints, cultural constraints that hinders women from being the best they could. And some of them, like a question that was raised, may not even know that they have such constraints. They just feel it is part of the normal life. So men are often the decision makers, whereas women mostly confine to domestic cause, and this ultimately affects them later in life, causing loss of self-esteem in their adult life. So it is important to understand and address this inequality in women empowerment in order to improve vaccination coverage, because they are the ones in charge of these children in most cases, and also the health outcome of every individuals in the household. So we developed a special varying effect model of which we used to look at the effect of women's empowerment on different childhood vaccination coverage in Nigeria using a spatiotemporal modeling framework. Now, measurement of women empowerment is always faced with a lot of irregularity in terms of definition and the measurement itself. In most cases, it depends on what you are measuring, who is measuring it, and even where it is being measured. We have a lot of differences based on what we are really measuring. But one important guiding principle is that it relates to enhancing capability of the individual. So equal access to resources and opportunity and having agency to use them to make choices and decisions. That is when we say that an individual is well empowered. So when it comes to household survey, there are several proxy variables that are collected to measure this empowerment indicator. So when you now have several variables again that tries to measure an aspect of empowerment, then the challenge again will be how to include these several dimensions in a modeling framework a lot of approaches have been suggested. There are transformative approaches. Some people use multivariate cluster analysis to identify empowerment patterns. Some use proportional positive outcomes from different domains of women's empowerment, just trying to bring out the positive responses and create what they call Femi index. And there are those who use factor analysis through component analysis also to pull the several variables together and then reduce them into a few dimensions that can now be used to measure women empowerment. So here we relied on this last one, that is a factor analysis approach, where we combine a lot of responses to create factor scores. And from the factor score, we generated our empowerment indicator. So for this study, we use the data from Nigerian Demographic and Health Survey for 2003, 08, 13, and 2018. We focus on children aged 12 to 23 months because this is the period we expect that they should have covered some basic vaccinations. So the empowerment indicators we look at, number one is participation in household decision making. And this is measured based on variables that determine if the person, that is the woman, decide on, who is the person that decide on respondent health care, large households, purchases, visits to families or relatives, and what to do with the money the husband earns. So now these questions, there are, I think, 3 responses to each of them. Whether there are 4, but we group them into 3 to state whether the woman participated in the decision, whether she took the decision alone. If she took it alone, that we give 3, that is 3. Whether she participated in the decision, that is herself, with probably the partner or someone else, that's 2. And if the decision was entirely taken on her behalf, then we coded that as 1. So we have these 4 variables that were looked at under this domain. Then the next one is empowerment regarding healthcare utilization. Here, the questions are meant to assess the hurdles that women face in an attempt to assess healthcare for themselves. 1, getting permission to go. Is it a big issue, or you can get easy permission to access healthcare? And getting money needed for treatments, not wanting to go alone, and distance to health facilities. And like I said earlier, we combined them in factor analysis and generated factor score. So the first score, we now generated it into tactile, that is 3 categories, and which we use for this. So we created dummy variables for empowerment as seen there, where the first category is termed not empowered. The second one is moderately empowered, while the third one is highly empowered. We did that for decision making and also for healthcare utilization. Then we considered 5 different vaccination types. The first one is 0 dose, which is taken as no DPT containing vaccine. Then we look at MCV, DPT complete, that is received 3 doses of DPT containing vaccine. We look at BCG, 1 dose of BCG, which is given at birth, and then all basic vaccination, that is, does the child receive all basic vaccination, which is defined as stated on the slide. Then our model, like I said, we adopted a spatiotemporal model where the response variable, which is each of those vaccination indicators, is now taken for Nigeria is divided into 774 local government. The data were collected on cluster basis. So from that now we generated some kind of latent variables for each of the local government in such that the ICA approach, that is the prior we used for the spatial component, was able to make some kind of a prediction for every local government within the country. So we have a logic model which is in this form, and then we have an interaction between each of the empowerment indicator and the spatial component, which is represented there. And then we assumed an ICA, which is intrinsic conditional autoregressive prior for each of the spatial domain. Then to our results. The first is the table that shows the number of children we included in the study and the number of women also based on their empowerment category as generated from our factor analysis. And we can see that, for instance, on decision making, we see that about 45% of the women are not empowered, while just 28% are highly empowered. But when it comes to healthcare utilization, about 40% of them are empowered, which is understandable because this has to do with just decision to, go for healthcare, but where this first one has to do with you participating in household decision making. Now, the maps generated from this analysis, the first one is the zero dose, which gives the predicted probability or the prevalence of coverage across Nigeria based on the different survey period. And we could see that there are a kind of north-south divide, particularly when it comes to 20, of course, is the pattern and more sustained in 2018. So here I assume that this is places we have many prevalence of the prevalence of zero dose children, that is children who do not receive DPT containing vaccine. Then these are the maps for the empowerment indicator, looking at the effect of the first one is healthcare utilization. This is for moderately empowered, and this is for highly empowered regarding zero dose, while the second one is for decision making also. And regarding, we can also see that there are patterns in it, such that particularly in this part of the country, there seems to be less utilization of, likelihood of using, effect of having becoming a zero dose is more in those places. Then this is for MCV containing, that's measles containing vaccine. Then also this is the predicted probability for rate, showing that low coverage in this part of the country, but about high in these places, also indicating some kind of north-south divide. And then this is the effect of the various empowerment indicators on measles containing vaccine as estimated. Then the next one is for DPT complete, that is taking the 3 doses of DPT. Again, we are having a kind of north-south divide in coverage, and then with more coverage appearing to be in the southern part of the country compared with what we see in the northern fringe. And then when it comes to the effect of the empowerment indicators, we have the maps also as these. Then we also have for BCG coverage still showing north-south divide, and then this is the maps for the various empowerment indicator, which also shows that particularly if you had followed the map of the empowerment indicator, you see that number one, there are a lot of variations when it comes to highly empowered, that it is for the moderately empowered category of the women. And again, it's, for instance, from this one now, it appears to show a kind of somehow north-south divide as well, where the likelihood of having taken BCG is less for children whose parents are, caregivers, sorry, the mother is highly empowered compared with what we see in the southern part of the country. Even that appears also slightly for the moderately empowered category. Then we have for the all basic vaccination. This again portrays a kind of north-south divide across the country. Then this gives us the estimate for the impact of the two indicators for women empowerment that were considered. So we can now conclude by saying that there are evidence of space-time variations for all the vaccination types during the survey period, with an apparent north-south divide for all vaccine type that were considered. And the coverage of all basic vaccinations particularly appeared to be low everywhere in the country, even though that also reflects a kind of north-south divide, but it is still low in every part of the country. And then there are more variations among the highly empowered, but relatively uniform when it comes to the moderately empowered. Of course, that is when compared with the less empowered category. So more apparent for decision making in the case of zero dose, and then relatively uniform pattern for moderately empowered, especially in the southwestern part of the country. And also that there are lower chances of vaccine uptake among the highly empowered in most northern locations across the country. So I want to thank you so much for listening.
Thank you, Ezra. We have a lot of time for questions, so.
Yeah, thank you very much, Ezra, for that lovely presentation. We know that the special work is heavily influenced by environmental covariates, like maybe vegetation, or things like distance to the nearest health facility, things like access to healthcare coverage, that kind of stuff. But I did not see those mediating factors in your model. So I don't know. And secondly, too, we have done a lot of work on vaccination coverage in Nigeria for BMGF. And one of the things that always comes out strongly is educational level. It does mediate vaccination coverage a lot. And also the definition for the 0 dose is another thing that is in contention. So these are things I want to learn from you. How do you manage these things as far as your work is concerned? Thank you. Yeah.
Okay. Thank you so much. Let me start with the 0 dose definition. I agree that it's in contention, but in, should I say, most cases, at least we have come across, it is assumed to be those with no DPT containing vaccine. And that was why we just adopted that definition and used for this work. Then again, the issue of education, I agree that empowerment has to do with the level of education. But if one looks at it critically, that can be a dimension of empowerment on its own. Just like we have decision-making and utilization of healthcare facilities, you can also look at empowerment in terms of literacy. And in that case, one can combine variables that indicate your level of literacy, whether you're educated, the level of education, and also whether you can read or write and all that. Then one can use that to create another empowerment indicator, which can just also be included with this one in order to face another dimension. Now, the issue of nearest to healthcare facilities and some of those other covariates, yes, they are fine. Number one, in our data source, those were not captured, but I know that one can get them probably from one or two other sources and then bring them in, which we did not do. But from our data source, which is DHS, there are a number of socioeconomic indicators that could have been brought in. But because we focus on predicting estimates at local government level, in which the data were not collected at local government level, but at clusters, different clusters. So we felt that we should, for now, focus on that because bringing in something that, those variables, we felt it may not be suitable. We tried it, but we felt it wasn't suitable because of our interest in projecting at local level. And that was why we excused that. But I agree that indicators like nearest to health facilities and all that can be obtained from some other sources and brought into the model. Well, we could explore that option.
Okay, thank you very much. So what we normally do with issues around having data at the LGA level, which is a local government level, which is smaller than, let's say, what you want to work with or bigger than what you want to work with. The DHS collected at cluster level locations, which are smaller than the LGA level. So you have the opportunity to aggregate those indicators to LGA level because you're interested in LGA level. So you move from the smaller level to the higher level because you're working on the higher level. So that can be done easily. Yeah, so you can consider that because what I saw was at the district level, which is the LGA level, and the data is collected at cluster level, which is smaller than the district level. So you can aggregate. That is possible. We have done that, yes.
Thank you. But don't forget also that these socioeconomic variables are collected at individual level. So if you want to do that, probably, well, it will be some variables that can easily be aggregated. For instance, now, education, which was collected as individual, except one tries to create a kind of latent variable that measures cluster level education. That's my own understanding.
So, for instance, education level, you might be interested in maybe those who don't have any education at all, or you're interested in those who have maybe tertiary level of education. You can find a proportion of those who had a tertiary or who have no level of education, and use that in your model. You get that. That is simple. You can do it.
It's okay.
You don't think so?
Thank you.
Yes, it's about a proportion of those who are maybe have no education, or proportion of those who had maybe tertiary education, and use that in your model. You can aggregate easily. Thank you.
Thank you. More questions?
Thank you for the presentation again. I was just looking at the data. You covered 5-year interval, and the last was 2018. So I was just wondering how current that could be. Is it that the data is so scarce to obtain, or if yes, what can we do to ameliorate this type of thing so that we can have current research?
Thank you so much. DHS data are collected at 5-year intervals. For Nigeria, well, there was a survey in 1990, in 1999 or so, then 2003, 8, 13, and 2018. 2018 is the most recent one that is available. There is the 2023 survey that is, I don't know whether they've concluded that, but the report has not been released. So that data is still not available. So 2018 is still the most current data that is available for this purpose.
Great talk and great questions. And that last question made me wonder, was I seeing correctly that there was quite a bit of change, sort of DHS to DHS between the districts that you presented? So it'll be really great to get that more recent DHS report released so we can see if things have changed further, if I was reading that right.
Okay, you are trying to say that probably the most recent one, when released, we should.
When I saw your 4 cartograms showing the way coverage has changed between years, absolutely awesome graphics, by the way. I thought it looked like maybe it was in the 0 dose one. But in one of them where I had tried to look kind of graphic to graphic, it seemed like there was a lot of change. Like early on, it was maybe in the West, and then later on it was maybe in the East. And
for instance,
this is one of them.
This is one of them. Yes.
Yeah. There's a lot of change from 2003 to 2013, right? So in the next 10 years, wow, we can't wait to find out what the next data series shows.
That actually was my question as well. If you look at 2013 versus 2018, the areas that have higher coverage of BCG. No, this is not coverage, right? This is
coverage.
Maybe I'm reading it wrong. Is this coverage?
Yes, this is the coverage, the probability. This is
okay. Do you know what is causing this trend? Because the region that has highest percent coverage of BCG in 2013 is very different than 2018. That's what AB, I think, was saying as well.
Yes, I just wanted to comment to say, I think probably the issue could be the population behind, because most of the times when you're handling data for Nigeria, population issues tend to be, because I think, when was the last population census in Nigeria? 2006?
2006, yes.
Yeah, so DHS sampling framework comes from, is based on that.
Based on that survey, yes.
Yeah, and hasn't been
based on that
updated.
since.
So I think most of these issues that we see in Nigeria are based on the population issues.
Thank you so much for that insight.
Yes, so just a quick one again. It would be useful to let us have some measure of certainty around your predictions, so we can put the prediction in context, because what we are seeing, that can also help some of us to make a judgment as to if the model is having some problem or not. But I haven't seen any measure for certainty, whether the standard error or the credible interval or something. I couldn't see any of that. Is there any reason?
Thank you. They are available, but
Okay.
you know, if we have to plot and generate another set of maps again for each estimate, there will be a standard for each map, another standard error. So we felt we are going to have a whole lot of maps, but they are available for every estimate.
Thank you for a fantastic presentation. Just looking beyond, like beyond any model, right? So you've presented this in terms of actual interventions. Are you suggesting that, okay, in terms of empowerment, like, more education campaigns or something else that would increase empowerment, if I may say very broadly? How does this model inform policy in a way? Like, what sort of interventions at a micro level, at a district or a sub-district level could happen, say, where, there's low BCG prevalence. So if you do X to empower women, you could, have higher coverage. So like, I'm just trying to see what the applications of such a model would be.
Thank you so much for that question. I will use comment one of the maps that shows, okay, for instance, this map now that shows that if you look at it, these are highly empowered women. So if you look at it, there is a kind of more variation than even for the moderately empowered based on the combination of the indices that we created. So what this probably is telling us is that, for instance, in this part of the country, an individual can be highly empowered to participate in healthcare, on healthcare utilization, but such is not translating to high vaccination coverage for the child. So that means that even though you are empowered, there are some factors that are at play. For instance, cultural values. One can be empowered to take his decision, but because of maybe some cultural values or whatever beliefs and whatever it is, so that may hinder such an individual from utilizing the opportunity. So one intervention could be, I don't know, around maybe making them to have a kind of change in belief or something that could encourage them to see that, yes, even though this is your belief, this is your this, and these are things that are very good for the child and all that. So a campaign in that direction, to me, I think would probably help, so that not just the fact that one is educated, one is empowered, though we didn't look at education here, but one is educated, one is, have the prowess to take decision, may not necessarily translate into taking that decision, except some other things are probably addressed. So I think a kind of campaign that will probably give a kind of reorientation might be useful in this case.
One quick question.
What's key then in this case is the context. I think if you included the context in the analysis, so if you are going to adjust the analysis, try as much as possible to include the context, because saying that people are empowered to take decisions or participate in decision making, but if the context doesn't allow, then what's the purpose?
It's okay.
Thank you so much. Thank you, Ezra,
Thank you
for
so
your
much.
presentation.